molecular biology. He is fellowship trained in sports medicine. He specializes in shoulders, knees, and elbows, and he does workers' compensation too. Dr. Gross has been voted one of the best doctors in America, 2007 to the present, and that is an honor given to only 5% of physicians practicing in the United States. And Dr. Gross joined the Optimal Work Comp Solutions Plus panel. That is a company that was formed by Barb Mays and myself, and we represent physicians who are work comp savvy and can be a resource to you in your work comp claims. This is what we do. We put together these talks so that the physicians can showcase their specialties, and hopefully you will gain some very good information out of this. Dr. Gross also handles Missouri and Illinois workers' comp for IME, as well as evaluation and treatment. And today's talk is on articular cartilage knee injuries. And now this is Dr. Gross's first time doing this talk, and we're going to have it videotaped because if you have any questions about what he's going to be discussing today, it might be the first time you've heard this information. And at some point later in the future, we can get this to you either via webinar or if you request that information from Barb Mays or myself. So if you do want to see this additionally, let us know as you leave, and we will make sure we get this information to you at a later date. And so let me introduce to you Dr. Lyndon Gross.
Yeah, no problem. All right. I have multiple microphones, so I guess you'll be able to hear me. I've always been told that I don't talk loud enough, and my staff's going to tell you that I talk too fast. So today I'm going to try to talk slower, okay, and try to give you all the information you need to know about this, and hopefully after this talk you guys will have questions that you want to ask me and we can talk about these different issues. So I'm going to talk about the treatment of articular cartilage injuries in knees, and what we're going to talk about are the treatment of focal injuries, small injuries to the knee. I think it's become more prevalent specifically in our workers' compensation patients that are aging. So when we get into the 40 and 50 and 60-year-old patients, we start seeing these chondral lesions. I'm not talking about osteoarthritis because that's a different treatment algorithm. I'm talking about individuals that have had a traumatic injury that caused them to have a focal cartilage injury to their knee. So when I examine my workers' comp patients, occasionally I think that they think this is what I'm doing to them. I'm actually trying to hurt them, but I'm not trying to hurt them. I'm actually trying to get a good examination of their knee and make sure that I am covering all bases. I like to examine them. I like to get a good history with regards to their mechanism of injury and try to determine if obviously that injury was caused the pathology that I'm seeing in their knee. I think there's a significant public health issue with regards to articular cartilage injuries. If you look at individuals that have had ACL tears, so we're looking at younger individuals that have torn their anterior cruciate ligament through some sort of traumatic injury, 28% of those individuals will have articular cartilage injuries. There was a great study that was done on professional football players at the draft combine. They actually took all these players and did MRI scans on them, and about 36% of those players had cartilage injuries and didn't even know they had cartilage injuries because they're not significantly symptomatic. If we look at the study that's shown here on over 3,000 arthroscopies, you can see that there are approximately 60% of those arthroscopies had cartilage injuries, either grade 3 or grade 4, and they're more prevalent in individuals over the age of 40. Again, if we look at this study where there were articular cartilage defects looked at in 1,000 arthroscopies, if we look at this, you'll see that grade 3, grade 4 injuries in greater than 1 centimeter. So 1 centimeter squared is about the size of the fingernail on your thumb. And you're looking at 40, 45 to 50-year-old individuals, and you're seeing a 7% rate of these injuries in these individuals, and that's significant. And the reason why that's significant is if you look at this study that was done on articular cartilage injuries, just focal injuries compared to osteoarthritis, they looked at individuals that had osteoarthritis that were going to need knee replacement. So these individuals are obviously significantly symptomatic. And they looked at the KOO score, the knee injury arthritis outcome score. They looked at those scores for those individuals compared to individuals that had articular cartilage injuries, focal injuries, and those scores were the same. So these individuals that have focal, small injuries to the knee are as debilitated is individuals have significant osteoarthritis of their knee, and they actually found that those individuals were even more debilitated than individuals that just had an ACL tear that needed a reconstruction of the ACL. So these become significant injuries for these individuals, and although we sometimes look at them and say, well, it's just a small cartilage injury, why does it hurt that much? It really does debilitate them, especially if they are doing any type of manual labor. What is articular cartilage? Well, articular cartilage is a resilient, wear-resistant, low-friction, high compressive surface on your knees. What it is it's like a covering over the bone. The bone has nerve fibers in it, the subchondral bone. That cartilage covers that bone and works like a shock absorber, similar to the meniscus in your knee, and it helps to protect that joint and allow the joint to move smoothly without any significant friction, and allows you to bear weight and to absorb that weight, similar to putting shocks on your car, so you have a very nice, stable ride. Articular cartilage is formed by chondrocytes. The chondrocytes are the cells in articular cartilage. They're mesenchymal cells or stem cells, and they produce that matrix or articular cartilage. I try to explain it to my patients as if you took Jell-O and you put grapes in it, and that Jell-O forms, and those grapes are suspended in the Jell-O, that's what those chondrocytes are. They're actually suspended in the articular cartilage, and they make the matrix. They make that articular cartilage matrix that allows you to absorb force. Now, those cells obviously synthesize, assemble, and maintain the matrix. They have no nerve fibers in them, and they don't have the capacity to divide or to replicate. So similar to when you cut your skin, you'll have a clot form there. You'll have mesenchymal cells come in. Those mesenchymal cells or those stem cells will actually divide, and they'll turn into epithelial cells, and you'll produce new skin. Cartilage doesn't have that capacity, so when those chondrocytes are damaged or the cartilage is damaged, it can't reproduce itself. It can't make new cartilage. And this is what I'm talking about. This is the articular cartilage. This is a schematic showing the bone, the underlying subchondral bone, and the articular cartilage with your meniscus here. And that articular cartilage covers the bone, allows it to absorb force, and actually helps with regards to trying to take pressure off the underlying subchondral bone. So how do we get these injuries? How do we get these cartilage injuries? Well, they can happen from sports activities. They can happen from work-related trauma. They can happen from other injuries. We do see them in individuals that have chronic instability. So individuals that have ACL insufficiency or ACL tears, we don't reconstruct the anterior cruciate ligament or the ACL in everybody because they're going to return to be a professional athlete. The reason why we reconstruct it is because if they have chronic instability of their knee, that chronic instability will cause them to damage their meniscus and also to damage their cartilage. And over time, those individuals will develop osteoarthritis of their knees sooner than they would if they never had an injury. So it's very important that individuals have any type of instability of their knee, specifically with their anterior cruciate ligament, have treatment for that. In addition, people can have pathological malalignment. They've had something happen to their knee. They may have had cartilage or meniscal or ligament injuries in the past. Now they have what we call a varus knee or a valgus knee. You've seen people that have bow-legged or knock knee. Bow-legged is a varus instability. A knock knee is a valgus deformity of the knee. And those individuals will actually overload their knee and wear out their cartilage, similar to your car being malaligned. If your car is malaligned and you put new tires on it, what's going to happen? You're going to wear those tires out the same way you wore them out before because the car is malaligned. OCD lesions or osteochondritis dissecans. That's a disease where the bone, the subchondral bone, actually dies, and then what ends up happening is because that bone dies, it becomes loose, and the cartilage over that area becomes loose, and you can get a large loose body in your knee. Meniscal deficiency. Your medial meniscus, the meniscus on the inside of your knee, covers approximately 50% of that surface. The lateral meniscus on the outside of your knee covers about 75% of that surface. When you take a portion of that meniscus out, that decreases the shock absorption of that side of your knee. So you're obviously going to put more load on your articular cartilage, that smooth surface on the ends of the bone, and that's going to cause that surface to wear out prematurely. And it's been shown in many studies that have gone on for years that taking out just 10% of your lateral meniscus can change the contact pressures by over 75%. So you're going to wear that side of your knee out sooner. And obesity in the presence of moderate malalignment. So I always tell my patients, when you walk, it's 2 times body weight on your knee. Go upstairs, 4 times body weight. Jog 6 times body weight, run 8 times body weight. I weigh 250 pounds. When I go upstairs, that's 1,000 pounds on my knees. Obviously, the only thing that absorbs that pressure is my cartilage, my meniscus, and my muscles. So obviously, if I weighed 400 pounds, that's going to put almost twice as much weight on my knees, and it's going to allow that cartilage to wear out sooner. What about healing of these lesions? And this is the problem we have with articular cartilage. The reason why articular cartilage injuries are so significant is because they don't have the potential to heal. Partial thickness lesions have no biological mechanism to trigger repair. So what happens is you can have a partial thickness lesion. It can stay stable for a long period of time, but we know just from looking at knees and seeing that people have large full thickness lesions that these lesions progress over time. Full thickness lesions have some propensity to heal. What will happen is you'll get new mesenchymal cells that will come into that area, or stem cells, but those stem cells won't differentiate into chondrocytes that produce normal cartilage. They'll actually be fibrochondrocytes, which will produce fibrinous tissue, which is not as resilient to pressure, and it will actually wear out sooner. I explain this to my patients like a cavity in a tooth. I tell them that the cartilage in your knee is like the enamel on your tooth. Has no nerve fibers in it, but the bone underneath the cartilage has pressure sensitive nerve fibers, just like the pulp of your tooth has nerve fibers in it. So when you wear out all the enamel on your tooth and you have a cavity, it hurts because that nerve underneath is exposed. It's the same thing with a articular cartilage, a lesion. When you wear out all that cartilage, so the bone underneath it that has pressure sensitive nerve fibers in it is exposed, that causes you to have pain. So it's like having a cavity in your tooth. How do we diagnose these? Well, when diagnosing these articular cartilage injuries, sometimes the individuals will be difficult to diagnose just because they may not have any specific symptoms. If they have an acute injury, they were at work, they got hit bluntly in the front of the knee by something and it compressed their knee and knocked a piece of cartilage off, obviously they're going to have bleeding and swelling, ecchymosis around that area. So they may have some signs of trauma, but the majority of the patients I see that have this come to me months after the injury, so they may not have any swelling whatsoever. The only complaint they may have is, well, I do activities and I have pain, and they may not even be able to localize the pain significantly. They just said, my knee hurts all over, but I know it's not normal. They may complain of some mechanical symptoms like catching, locking in their knee, sometimes even giving way of their knee. Their physical findings, if it's an acute injury, we may see significant swelling or an effusion of their knee. If it's a chronic injury, we may not see any of the swelling, but they may just have pain with range of motion. They may have pain with palpation of the knee. They may actually complain of some mechanical symptoms or even have some crepitus, some grinding in their knee when you move their knee. In addition, the X-ray studies may show no significant findings unless they have significant osteoarthritis or degeneration of their knee. When we look for studies that we can do to help us differentiate or diagnose these, MRI scans are very good, but MRI arthrograms are actually better. An MRI arthrogram is they inject dye into the knee. That dye will actually outline the articular cartilage surface, and if there's a defect in the surface, that dye will actually flow into that defect and allow you to see it better. So if an individual has a big swollen knee with an effusion, it's like having an arthrogram, but the majority of patients I see, like I've said previously, have no swelling of their knees, so it's very difficult to diagnose those on a regular MRI scan. In addition, arthroscopy is the most accurate way to diagnose these. So some individuals may have an MRI scan that doesn't show significant abnormalities, at least a normal MRI scan, and a lot of times you'll have to do an arthroscopy of their knee just to assess that area to look and see if there's a cartilage lesion. So that's the most accurate way to diagnose a cartilage lesion. This is just showing you an MRI arthrogram of a knee, and this is an individual that was at work, got hit in the front of the knee with the side of a wheelbarrow, came in and said, you know, I had pain and swelling initially. My pain and swelling went away, but now I'm still having some pain occasionally when I squat, when I kneel, and I do certain activities. And on this MRI arthrogram, you can see the white dye here is the arthrogram dye. Here's this cartilage surface, and you can see there's a hole there. Cartilage here, there's a hole where a piece of cartilage has been knocked off, and here's the rest of the cartilage here on the trochlear grooves. And this is just an arthroscopy view of that knee, and you can see here's the normal cartilage here, and here's the area where the cartilage has been damaged, and you can actually see the bone underneath there, the subchondral bone. So how do we grade articular cartilage injuries? Well, we use an outer bridge classification, and we grade them based on what we see at the time of arthroscopy with regards to the cartilage, and we grade them. Grade 1 is just softening of the cartilage. And even with softening of the cartilage, that decreases the shock absorption of that cartilage and allows some of the pressure from your knee to be transmitted to the underlying subchondral bone. So if anyone in this room has ever had a toothache, when your enamel in your teeth gets thin and they become sensitive to hot and cold, that's what we're talking about. When you have a grade 2 lesion, there's some fissuring of the, or fibrillation of the cartilage, so the cartilage itself starts to break down. A grade 3, you start to see fissuring in the cartilage, and in grade 4, you actually have a full thickness lesion. And once you get that full thickness lesion, when you get to grade 3 or grade 4, you're going to start having more significant problems with regards to weight-bearing type activities, and you're going to have more pain in your knee. This is just an arthroscopic demonstration of all of those. This is grade 1, where the cartilage is a little bit soft. It still looks pretty normal, but when you press on it with a arthroscopic probe, you can see that the cartilage is soft. Here the cartilage is a little fibrulated. Here you can see a fissure in the cartilage. This piece of cartilage is actually peeling off the bone. And here is a grade 4 lesion where there's a full thickness lesion of cartilage down to the subchondral bone. The size of the lesion is very important. Small lesions, less than 2 centimeters, actually less than, say, 1 centimeter, tend to be well bordered by normal cartilage, and that protects that lesion from breaking down more. Now, over time, will that happen? Yes, it will. It's like wearing a hole in your pants. Obviously, you can have some wear in your jeans, and you can wear those jeans for a long period of time, but eventually those jeans are going to tear over time. So a well circumscribed lesion or smaller lesion tends to be protected, so it won't degenerate further. It will happen over time, but it will happen slowly. Larger lesions that are not well bordered tend to degenerate or tend to increase more quickly. We usually grade these as small as 2 centimeters squared, a medium is 2 to 10 centimeters squared, and a large is greater than 10 centimeters squared. And a large lesion is significant, usually more consistent with somebody having more global osteoarthritis of their knee. I always tell my patients it's like having a pothole in the street, this lesion in your knee. So if you have a small pothole in your street and it's not as wide as the tire of your car, you'll drive over that pothole forever and you may not even notice it's there. Once that pothole gets larger than the width of your tire or deeper, what will happen is your tire will bottom out when you go over it and your car will go clunk, and then you'll call your municipality and you'll ask them to come and fill in that hole. Similar to what happens with these patients. Once that hole gets big enough, they're going to have more significant problems, they're going to have mechanical problems and pain, and they're going to complain about that issue. So what's the treatment, or what are our treatment goals with articular cartilage injuries? Well, our treatment goal is obviously to relieve the symptoms the patient's having. We want to get rid of their swelling. We want to get rid of their pain. We want to make sure they don't have mechanical symptoms. We want to allow them to return to work, specifically if it is a workers' compensation patient, so they can go back to work and do the activities they do at work normally. Also, we want to return their knee function. We want them to be able to bend their knee without problems. We want them to be able to feel like their knee is stable, to have good strength in their knee. And we want to do this with minimal morbidity. We don't want to do some sort of operation that's going to cause them significant problems in the future or cause them to have multiple other operations afterwards. Indications for treatment are symptoms. Obviously, as I discussed earlier, with the study that was done in the NFL, that was thousands of players that were coming in for their physicals, and they did MRI scans on the majority of these individuals, and a lot of them had full thickness cartilage lesions, usually less than 2 centimeters, and those individuals weren't symptomatic. So you get 36% of professional football players have cartilage lesions in their knee and aren't having any symptoms. So obviously, those individuals we're not going to treat. We're very cautious with them and want them to know that there is a lesion there that could potentially become symptomatic and can enlarge, and we may need to do something about it. But if they're not having symptoms, it's very hard for me to tell somebody to have an operation. Second of all, you want a focal chondral lesion. So you want a lesion that's small. You don't want a very large diffuse lesion. And you want to have hopefully 1 lesion or 2 lesions. You don't want multiple lesions. Multiple lesions usually don't do as well. And you don't want lesions on both sides of the joint. So if you're looking at the knee, we're talking about the femur, the thigh bone, and the tibia, the shin bone. If you have a lesion on the femur and a lesion on the tibia, that's usually not going to do well if you do any sort of cartilage restoration procedure. You also want to have normal or correctable knee alignment, normal or correctable knee stability. You want to have functional meniscal tissue, and you want to have had that person fail non-operative management before you start something surgically. When I talk about your alignment, this is a normal knee. So if you drew a line from the center of your hip to the center of your ankle, it should go through the center of your knee. This is somebody that has a varus knee, or their knees are bowed, and that line from the center of their hip to the center of their ankle is going to go through the inside or fall to the inside of their knee. This is an individual that's had some wear of the inside of their knee. If you were to do surgery on that individual for a cartilage restoration procedure and you were to fix the cartilage on the inside of this knee, it would be just like putting tires on a car that's malaligned. You're going to wear those tires out in the same exact place and it's not going to work. The same thing goes for somebody that has a valgus knee, where they have a knock knee, where they've actually had some damage or their malalignment is on the outside of the knee, it's lined from the center of their hip. The center of their ankle is going to go through the outside of their knee. So you have to correct their alignment if they have an alignment problem prior to doing any type of cartilage restoration procedure. In addition, what we talked about earlier with ACL insufficiency or instability to the knee, if you have any instability to the knee, you have to take care of that prior to doing a cartilage restoration procedure, because if they're still unstable, they will wear that cartilage out in the same place. So it's foolish to do that operation if you haven't done that. They have to have normal meniscal tissue. If they have no meniscus, there's no shock absorber there. The reason why the cartilage is worn out is because there's no shock absorber. So if you put new cartilage in there, it's going to wear out again because you don't have a shock absorber. So you may need to do a meniscal transplantation in addition to that cartilage restoration procedure. There are some clinical considerations too. Size of the lesion. Smaller lesions tend to do better than larger lesions, and that sort of makes sense. If you have a smaller lesion, it's probably easier for that lesion, no matter what particular type of operation you do, to heal that lesion as compared to a larger lesion. In addition to quality of the lesion, if that lesion has good bordering cartilage around it, it probably has a better chance of healing than if the cartilage is more diffusely damaged. In addition, you want to have intact subchondral bone, the bone underneath the lesion. If that bone is intact, that works better for multiple cartilage restoration procedures than it does if that bone's been damaged. If that bone's been damaged, not only do you have to replace the cartilage, but you have to replace the underlying damaged bone. You want patient quality. You want a patient that's able to do what you want them to do afterwards, rehabilitation-wise. No matter how good a surgeon I am or anybody else is that does this type of procedure, if the patient doesn't do the right rehabilitation afterwards, it will fail. So if we do one of these procedures and the patient has to be non-weight bearing for 6 weeks and they walk around on it, it will fail, it won't work. You don't have to worry about it. So you need to have a compliant patient. And you also have surgeon-related issues. These are not standard operations that anybody does. These are operations that are specialized. The individuals that do them need to have done many of these operations. There are many pitfalls that happen with these operations with trying to manage these patients, and you need to be able to do those things. And if you haven't done this, or you're just somebody that's going to dabble in it, you'll find out that you're going to have significant morbidity associated with it, and you may have many complications that you never would have expected. So this is a localized lesion. This is a localized lesion. There's good cartilage bordering it. This is a lesion that may be amenable to a cartilage restoration procedure. This is a more diffuse lesion with missing meniscus and a lesion on the other side of the bones. This is the femur. Here's the tibia. The meniscus is, parts of the meniscus has been taken out. There's a large lesion here, but there's a lesion on the tibia with exposed subchondral bone. So the bottom line is that individual is not a candidate for a cartilage restoration procedure. It's probably more of a candidate in that case for some sort of arthroplasty type procedure. This is a patient that you don't want to do a cartilage restoration procedure on, because this guy doesn't care and he's going to do whatever he wants to do regardless of what you do. So if you see that patient walk into your office, you're probably going to tell him that you're not a candidate for this type of operation because I don't think you're going to be a compliant patient. In addition, as I stated earlier, you really have to do a lot of these operations because there are a lot of pitfalls with regards to doing these operations, and these patients have a prolonged rehabilitation period. You need to be able to make sure that you understand not only doing the operation, but doing the rehabilitation and where they are in their rehabilitation, because sometimes patients may be going slower and maybe going faster. You need to know, is this correct or not? Is this patient having a problem, or do I need to do something else with him? Or is he just progressing slowly because that's what happens when I do this type of operation? So you want to try non-operative management. I would tell you that non-operative management is probably reserved for patients that have very small lesions. So definitely less than 2 centimeters, and I would probably say less than 1 or 0.5 centimeters. And it's been shown in the literature that those lesions tend to be stable for a period of time before they enlarge, and some individuals can do very well with non-operative management. They may have to modify their lifestyle. So they may have somebody that is an avid runner and has a small cartilage lesion. You may have to tell them you can't run as much as you did. You may need to cross-train. You may need to swim. You may need to bike to improve the longevity of your knee and prevent this lesion from increasing in size. You want them to do some formal rehabilitation. As I talked about earlier, the only thing that absorbs force in your knee when you do activities is your cartilage, your meniscus, and your muscles. If you have a cartilage lesion, you really can't change that if you're doing something non-operatively. So the only thing you can change in that equation is to strengthen the muscles around your knee so that they will absorb some of the force that that cartilage is not absorbing. Orthotics or unloader braces. It's like trying to realign your car. So you can put an orthotic in their shoe or have them wear an unloader brace, which will actually put pressure on the opposite side of their knee where they don't have a cartilage lesion. So if they have a cartilage lesion on the inside or medial side of their knee, you want them to wear a lateral unloading brace or a valgus unloading brace to put pressure on the outside of the knee where the cartilage is good and less pressure on the inside of the knee where the cartilage is bad. Counterprotective supplements, or actually non-steroidal anti-inflammatories is next. Taking medications like Motrin, Aleve, ibuprofen, naproxen. Those are drugs to try to affect the symptoms that those patients are having, the pain, the swelling. So it's not going to change the fact that they have a cartilage lesion, but hopefully it will treat some of the symptoms they're complaining about and make them feel better. Counterprotective supplements like the glucosamine and chondroitin sulfate, taken to try to improve the remaining cartilage or try to make that remaining cartilage healthy. It's not going to help you grow new cartilage, but hopefully the cartilage you still have in your knee will be improved by these drugs. Corticosteroid injections, I tend to use these more in patients that have an acute injury or they're having significant pain. They may have a chronic injury and they've somehow aggravated that or in workers' comp terms, triggered or precipitated to become symptomatic. What you want to do is try to get them back to the baseline. So you may give them a corticosteroid injection to decrease the inflammation to make their knee feel better. It's not going to change the fact they have a chondral lesion or a cartilage defect, but it may make their knee feel better. And viscosupplementation, injecting them with hyaluronidase or hyaluronic acid. What it is when your knee is healthy, the lining of your knee, the synovial sites, produce a small amount of fluid. That fluid bathes your cartilage. It gives nutrition to your cartilage. It helps with the friction in your knee. When you start having problems, when you start having cartilage lesions, those cartilage lesions, when the cartilage breaks off, not only irritate the inside of your knee, but they produce chemicals that actually cause your knee to become angry, and you get that effusion or the swelling in your knee. So viscosupplementation injections help to improve pain. They help to decrease those enzymes that are causing your knee to become inflamed, and they actually help to relubricate your knee and stimulate those synovial sites or lining of your knee to produce more normal fluid to hopefully make your knee more normal. So this is what I see in the office all the time. The patients ask me, how long do they really have to listen to me because I get long-winded when I'm talking to them. But with this, again, I can't overemphasize the fact that your patients have to be on the same page with you if you're going to do this operation, because you're going to see them for a long time. They're going to see you for a long time. They're not going to like you, and you're not going to like them sometimes. But overall, at the end, it works. They get better, and they get back to the activities they want to get back to. So non-operative treatments. There's multiple different types of non-operative treatments. The first is just to do a palliative procedure. So we talked about how the cartilage and those enzymes that are released from the degenerated cartilage can irritate your knee. Well, you can just go in there and say, I just want to wash all those enzymes out, or I want to take all that loose cartilage out. So you can do a debridement or a joint lavage, and we'll talk about those and the results of those. You can do an intrinsic stimulus to repair that area. You can say, you know what? I know that if I am able to abrade the bone or able to put holes in the bone, it'll bleed. And that bleeding will bring new mesenchymal or stem cells in. And those cells hopefully will produce some sort of cartilage-like substance on that area to coat that area. And that's what you do by recruiting these mesenchymal cells for the purpose of forming repair tissue. You can do an abrasional chondroplasty or microfracture, and we'll talk about both of those. You can do a cell-based or biological approach where you're actually saying, you know what, we're going to actually try to reproduce cartilage. We're going to try to somehow make chondrocytes, or at least take chondrocytes and manipulate them into making new cartilage in this environment. And this can be done by taking these chondrocytes, amplifying them outside of the knee because they won't reproduce or they won't multiply in the knee, and then placing them back in and trying to produce new cartilage in this area. That can be done with natural tissue grafts. It can be going autologous chondrocyte implantation or matrix-induced autologous chondrocyte implantation. I'll talk more about autologous chondrocyte implantation, or ACI, because that's what's available in this country. MACI, or matrix-induced autologous chondrocyte implantation, is done in Europe. It's actually very good, and it probably will be approved hopefully within the next 2 years for the United States. Whole-based cell transfer, sort of like doing a hair transplant, saying, you know what, there's no cartilage there, but is there a way for me to take cartilage and bone from another area of the knee or from a cadaver possibly and put it into this area so that I replace that? And that can be done with autografts or an osteoarticular transplantation with your own tissue, or allograft. You can do it with fresh frozen or fresh osteoarticular transplants with allografts, where you take cadaver tissue and you actually transplant it into that area. Usually we like to try to use some sort of algorithm with regards to how we treat these individuals. So individuals have lesions that are less than 2 centimeters. These are smaller lesions. If it's a primary treatment, so this individual's had no other treatment before, you'd like to try to do something, if they're low demand, like a debridement of that area, and we'll talk about the results of that, or some sort of marrow stimulation technique, like a microfracture or abrasional chondroplasty. If you have a high demand patient, you might do the debridement or the marrow stimulation, but I think you're probably going to end up more doing an osteoarticular autograft, or taking bone and cartilage and trying to replace that area. And if it's a secondary treatment, somebody that's already failed treatment, you're probably going to look, especially even if they're low or high demand, and doing the osteoarticular autograft or some sort of autologous chondrocyte implantation. If you have a larger lesions are more difficult to treat, and they don't heal as well. Even for a primary treatment in a low demand patient, although you can do a debridement and marrow stimulation, most likely you're going to end up with an osteoarticular allograft, where you're going to use cadaver tissue. And we're going to talk a little bit more why you would do that in a larger lesion. In a high demand patient, obviously you're going to do an osteoarticular allograft. If it's a secondary treatment or a salvage treatment for somebody that's already had some treatment option, again, you're going to, even in a high or low demand patient, you're either going to do an autologous chondrocyte implantation, or ACI, or an osteoarticular allograft, or OATS procedure. So let's talk a little bit about lavage and debridement. Lavage and debridement is just going into the knee, doing an arthroscopy, washing out all those bad humors, as we would call them, or those degenerative enzymes, taking out any loose cartilage, any loose bodies, and just trying to wash that knee out and try to make it a little more normal. Obviously, you can do that just with irrigation. You can do irrigation and debridement, which will actually improve your clinical results. But you're removing debris and inflammatory fluid, but you're not doing anything to correct the underlying cartilage damage. So you're just washing everything out, taking out any loose bodies, trying to make their knee feel better. When we look at the results of this, and there aren't many studies recently on this because it's something that we try to use very sparingly because it usually doesn't work long term. And this is a study actually showing a prospective randomized study on 76 knees, follow-up of 4.5 years. And these individuals had grade 3 or grade 4 changes in the medial femoral condyle. They did lavage versus lavage and debridement. The individuals couldn't have had symptoms for more than 1 year, no prior surgery, normal radiographs, so they didn't have arthritis. And when they looked at this, about 65% of the people with just debridement, lavage and debridement, were pain-free at 5 years, whereas with just lavage, only 11% of those patients at 5 years were not symptomatic. So it does work for a group of individuals, but those results usually drop off significantly after 5 years. What about microfracture? Well, what you're trying to do with a microfracture is actually trying to stimulate the underlying bone. So the problem we have with articular cartilage is that when you damage it, those chondrocytes, as I discussed earlier, don't reproduce. They don't divide like normal cells to produce normal cartilage again. So what you do is you actually go to the subchondral bone, the bone underneath the cartilage in that area, and you put holes in that cartilage to stimulate that area to bleed, and that bleeding brings new mesenchymal or stem cells in that can hopefully produce new cartilage. Unfortunately, those cells don't become chondrocytes, they become fibrochondrocytes, and they produce cartilage-like tissue, but it's not like normal cartilage. So what you do is you debride any unstable flaps of cartilage, you take off the decalcified cartilage layer with a curette, and then you're going to place these holes with awl 3 to 4 millimeters apart. And those holes penetrate the subchondral bone and allow the bone to bleed, and you get a blood clot there. That blood clot is important. That blood clot brings those new cells in. Those new cells will then differentiate into fibrochondrocytes and produce that cartilage-like tissue. And it's fibrocartilage. It's not normal hyaline or articular cartilage. And this is just an individual operation I did. You can see the chondral lesion. What ends up happening is we're going to debride that chondral lesion back to a stable rim, and then we're going to use an awl to produce these holes in the bone, and those holes in the bone will bleed once we put the tourniquet down. This is a second look. I had to operate on this individual for another problem, and you can see this is where the new cartilage is formed. But when you look at that cartilage and you probe it, that cartilage is not hard or not durable like the normal cartilage here. It's a little bit softer. When we look at the results of microfracture, this is just the results in a study with traumatic lesions. This was 100 patients, average 6-year follow-up. They assessed them both preoperatively and postoperatively, objectively, and they found that there's a statistically significant improvement with regards to pain and swelling in these individuals after a microfracture. This improvement actually continued for almost 2 years after the operation, and 86% of those patients rated their knees as normal or feeling nearly normal. They didn't see any statistically significant difference between where the lesions were on the femoral condyle, on the trochlear groove, on the patella. In addition, larger lesions tended to do poorer than smaller lesions, which is what we see with some of the other cartilage restoration procedures. And in addition, lesions treated within 3 months of the injury tended to do better than chronic lesions. So more acute lesions tend to do better than chronic lesions. If we look at this in osteoarthritic knees, because there are individuals who tend to do microfractures in osteoarthritic knees, if we look at this study in patients over the age of 40, there was some improvement in pain and swelling, and in their LISM and tenor score. LISM score is actually just talking about the symptoms they have. Do they limp? Do they have pain? Do they have swelling in their knee? The tenor score is more of a activity score. So if you're looking at a tenor score, it goes 0 to 10. 0 means you can't do anything. 10 means that you're playing a professional sport. Usually a laborer, say a heavy laborer, would be a 5. And if you look at these patients, 20% of those patients required additional procedures within 5 years of the initial procedure. So what happens is microfractures usually do very well initially and give people improved pain, improved function, but over time they wear out, or that cartilage, that fibrocartilage that's formed there is not less durable and resilient, and it wears out again. This is an evidence-based study where they looked at 28 studies, and this is 3,122 patients. Average follow-up was 41 months. 5 studies actually had follow-up more than 5 years. When they looked at this, microfracture definitely improved these knees the first 2 years, but what they found out is that the results of that actually dropped off after 2 years, and those individuals started having more pain and started having further procedures with regards to this. And it actually, they found out that some of the things that were significant in that were age, size of the lesion, and chronicity of the lesion. So if you had patients that were older, patients that had larger lesions, patients that had more chronic lesions, they tended to do worse long-term with regards to microfracture. What about autologous chondrocyte implantation, or ACI? It's a biologic solution. What you're trying to do is you're taking chondrocytes out of the knee, and you're taking them out. There's a company called Genzyme that can manipulate these cells to divide, to multiply, and you multiply them multiple fold. And then you're going to take those cells and put them back into the knee, and hopefully they're going to produce new cartilage, or normal cartilage, as opposed to when you do a microfracture and you get mesenchymal cells or fibrochondrocytes that produce that fibrocartilage. And what I tell my patients, it's like filling a pothole. You have a pothole here, you're going to put a little cover on there and put some new material in there, and that new asphalt is going to fill that hole and excuse me, and improve that pothole. So what we do with an ACI is we'll go in and we'll harvest cartilage. We'll take our lesion and we'll put a membrane on that lesion. You can either use periosteum or a biological membrane. And what you're going to do is you're going to inject your cells underneath that membrane. Those cells are going to adhere to the bone, and then they're going to produce new cartilage in that area. So this is just looking at an operation I've done in the past. Here's a cartilage lesion to the patella, normal cartilage here and here. There's this almost full thickness lesion here. we take a little piece of cartilage out of the knee from an area where they don't weight bear, where they don't put any weight. And then what we're going to do at a later date, once this cartilage has been amplified, these cells are sent, that cartilage is sent off, the company degrades the matrix, takes those chondrocytes, manipulates them to multiply, and then we're going to take and open the knee up, and we're going to put a membrane on and inject those cells underneath that membrane to produce new cartilage. Again, this is an individual that has a lesion to the medial femoral condyle, meniscus looks normal, cartilage underneath the kneecap looks normal, but there's a cartilage lesion with the knee open. This is a large lesion. It's about 3 centimeters by 1 centimeter. So it's a large linear lesion. We're going to put our membrane on and inject those cells underneath the membrane to produce new cartilage. So if we look at the long-term follow-up of this, if we're looking at follow-up after ACI, this is just a study with 224 patients where they use a Lysum, Tenor, and Peterson scores, 10 to 20 year follow-up with a mean of 12-year follow-up. 92% of those patients were satisfied and would have the operation again. And all of them had improvement with regards to those scores. So all of those scores improved in those individuals. If we look at this in a diverse population of patients, this is 137 patients with mean size of the defect is 5.2 centimeters. So these are fairly large defects. Usually the majority of these patients were 30 years old, follow-up of 4 years. They used the Lysum and the IKDC scores, and they found there was significant improvement with regards to these patients. Objectively, 75% of those patients were complete or mostly satisfied. Objectively, 65% of these patients had Tenor scores of 6 or greater, meaning that they could return to recreational activities. So a 5 is some individual that does heavy manual labor. 6 is somebody that can return to recreational activities such as playing tennis, skiing, jogging. What they found is age, obviously in workers' compensation, were independent predictors of the Lysum score. So the score with regards to their symptoms, do they limp, do they have swelling, do they have pain when they get dressed in the morning, was more subjective with regards to age. So older patients had more problems with that. In addition, workers' compensation patients, as you would expect, would have more problems with that. 16% of these patients required a second operation. It's not uncommon with any of these cartilage restoration procedures to have individuals, usually probably about 20% of them will need some sort of further intervention with regards to surgery. Occasionally with an autologous chondrocyte implantation or ACI, the cartilage you put in there will actually overgrow, or they'll have scarring in their knee, and you may need to go in there and debride that so that they don't have any crepitus or continued pain in their knee. And 6.4% of these individuals had clinical failure and had to undergo further intervention. The majority of those individuals would undergo either a OATS procedure with an allograft or some sort of arthroplasty type procedure. What about osteoarticular transplantation with an autograft with your own tissue or an OATS? What you're trying to do is you're taking a round plug of cartilage and bone, and you're actually taking it out of an area where you don't weight bear and putting it in the area where you weight bear, where you have the cartilage lesion. So it's like doing a hair transplant. That's what I tell my patients. Obviously, it's good for smaller defects, and I'll talk a little bit about why you want to use your own tissue for smaller defects and use cadaver tissue for larger defects. And the good thing about this is you're taking normal cartilage and putting it into this area. So you don't have to wait for the cartilage to grow. All you have to wait for is the bone to heal the bone in that area. So it's probably the best alternative with regards to a cartilage restoration procedure is to do a osteoarticular transfer with your own cartilage if possible. There's a significant increase with regards to the knee score, so those individuals do get better, but there's some definitive donor site morbidity. So I always explain to my patients, it's like doing woodworking. It's like putting dowels into wood. So if anyone here has ever done woodworking where you're making something and you make these round dowels that go into the wood to hold the two pieces of wood together, that's what you're doing. You're making these dowels and you're putting them in the knee to fill up that round lesion where you're missing cartilage. The problem you have with this, though, is you're taking this cartilage from an area where you don't weight bear and putting it in an area where you do weight bear. So you can see there's not a lot of area here to use. So when these areas get larger, your defect gets larger, you don't have enough cartilage to take from the other portion of your knee where you don't weight bear to put in that area. And if you take too much cartilage from this area where you don't weight bear, it causes the bone to collapse here, and then you have another problem in that area. And I explain to my patients, it's like a hair transplant. If you have a large bald spot like this, there's no way you can take hair from the back of your head and put it up here to cover that area. So you can use it for very small areas. For larger areas, it's not appropriate. And this is just an operation I've done where you can see there's a small lesion. This is probably about a 2 centimeter squared lesion on the femoral condyle. You can see that the cartilage on the tibia or the the shin bone and the meniscus looks normal. And then what we do is we do this operation open. It's more difficult to do arthroscopically, and I think making a small incision and doing open, you can be done more appropriately. So we make a small incision, and here are the 3 plugs that we put in to cover that area, to cover this area here. When we look at the results of OATS, there are many studies out there to show that there are good to excellent results. This is just one study looking at OATS with autografts versus microfracture even. 60 athletes, mean age of 24, and they range from 15 to 40. 3 to 10 year follow-up with tenor scores. So they actually looked at these individuals at 3 years and then at 10 years and looked at what their activity levels were. And what they found is there was a statistically significant better result with those compared to microfracture. They did have some failures, about 26%, including 14% in the OATS and 38% in the microfracture category. So what that shows you is that the OATS does work better than microfracture. I think it's the best operation if you can do it, if you have a small enough lesion. It does give you good improvement, and all these individuals actually had tenor scores of 6 or better, which means that they would obviously be able to do recreational activities and do heavy manual labor. What about osteoarticular transplantation with allografts or using cadaver tissue? What you're going to do is you're going to use fresh or fresh frozen osteoarticular allografts or cadaver tissue. And you're using this for larger defects. You're using this for defects that are greater than 2 centimeters squared, where you're not going to be able to get enough of your own tissue to do this cartilage restoration procedure. Obviously, you're going to press fit these grafts in. You can use bioabsorbable screws or metal screws, but usually you can press fit it in, similar to what you do with a osteoarticular transfer with an autograft, although the plagues are somewhat bigger. Usually for larger lesions, you can use them when other methods fail. So you could have done an ACI or a microfracture and you find out that the patient still has pain. This is a salvage procedure that you can use, and it works even better if there's been any damage to the underlying subchondral bone. So not only do they have cartilage damage, but they're missing bone underneath there. This is a good indication to do this operation. Obviously problems are due to graft failure. You have to recognize that that graft, that cadaver tissue has to heal to your tissue. So that cadaver bone has to heal to your bone, and then your bone is going to actually do what's called creeping substitution. It's actually going to substitute or it's actually going to grow into that cadaver bone and replace it. The cartilage on the top stays the same. That can fail, and if that fails, that plug will become loose, and then the patient will have the same problem. Chondrocyte death. You try to use fresh or fresh frozen allografts rather, because the cartilage cells in those allografts will be alive. If you freeze the allograft, so if that allograft is frozen, those chondrocytes will actually die. So when you put that graft in there, there's no alive chondrocytes in it, and that matrix of the cartilage will actually degenerate over time because there's no chondrocytes to create that matrix or keep that matrix healthy. Obviously, there's disease transmission, although it's very low. The majority of these allografts are actually tested. When you have a frozen allograft or a preserved allograft, those allografts that we use for instance, for ACL reconstruction or for bone grafting, for trauma, for fractures, that tissue has actually been there, and they usually have 4-week period where they can actually test that tissue to make sure it doesn't transmit anything like HIV, hepatitis, or any other type of viral or bacterial infections. When they do a fresh frozen allograft, what ends up happening is they send that out and they only have 14 days. So they test it and they have to reuse it within 14 days or that allograft will go bad. So they do test it for HIV and hepatitis. I can tell you that I have not seen one reported incidence of transmission of hepatitis or HIV from an allograft, although the literature states that the risk is 1 in a million. So although I haven't seen it, I'm sure that there's somebody out there that's going to say it's happened. Average time to obtain an allograft also is 3 to 6 months. When you do an allograft, you have to actually send x-rays of your patient with markers out because those x-rays usually are magnified. So you have to send these x-rays out to the companies that procure these allografts. They have to find an allograft that's the exact same size or close to the same size as your patient. So obviously, if I was doing this in a small patient, they wouldn't want my knee because I'm a bigger guy, I have a bigger knee. So the radius of curvature of my condyle is going to be different. So my cartilage, or that piece they try to take out, is not going to fit well in that individual that has a smaller knee. So sometimes it takes 3 months, sometimes even up to 6 months before you can get an allograft, because they have to wait and find one that's appropriate, and then they have to call you and you have to be able to do that operation. Sometimes that logistically is difficult because the patients have to be on call. It's almost like when patients need heart or lung transplants and they're on the heart or lung transplant list. When their number comes up, they get called, they have to be ready to go to the hospital, because if they're not, then somebody else is going to get that heart or lung. It's the same thing with these allografts. They'll call you and say, okay, we have an allograft, we can have it shipped to you in 2 days. It has a shelf life of another 5 days after that, and you have to call the patient and say, okay, I have it, let's go. You know, so you have to be ready to do it. So what you're doing is you're actually taking this piece of cadaver, cartilage, and bone, and you're putting it into the area where you're missing cartilage. So this is an individual I saw, and she came into me with a loose body in her knee. She said that I had been walking around, not having any problems. All of a sudden I went and played volleyball tonight. I felt something pop in my knee, and now I feel like something's locking and catching in my knee. My knee is big and swollen. It's not, it doesn't feel well. So when I looked at her arthroscopically, you can see here's the area where she has a lesion. And this is probably, I'd say about a 3 centimeter lesion. And you can see this is pieces of cartilage that came out. Those are the little areas of cartilage. So what we did is, after taking that out, I told her that she was going to need an osteoarticular transfer with an allograft. So we sent her x-rays. We procured a specimen. It took about 4 weeks. And she came back, and this is what it looked like when we came back. Here's the area. Here's her knee opened up. What we do is we actually make that area more round. We can drill it. And then we put this piece of cartilage and bone in like this to fill that area. So if we look at the results of osteoarticular transfers with allografts, this is just a study on 66 knees in 64 patients, mean age of 28, ranging from 15 to 54, mean follow-up of 7.7 years, ranging from 2 to 22 years. The mean allograft here was much larger than the one I just used, so these were 7.5, and 47 of those knees were rated as good as excellent, so that's 72%. 7 of those knees, or 11%, were rated as fair, and 1%, one knee or 2% were rated as poor. If we looked at return to activities, this is just another study looking at the return to activities after a osteoarticular allograft, and this is actually in professional athletes. I looked at 43 athletes, mean age of 32.9 years. Well, actually not all professional athletes, some of them weren't. 18 to 49 years. Average was 2.5 year follow-up, and they're evaluated by the IKDC and the KU scores. And they found out that full return to activities in 79% of these athletes, with limited return to activities in 88%. Time to return, though, was somewhat longer, 9.6 months. So when we look at this, if we're looking at what I do or what my protocol is for these patients, if we're doing a debridement, just doing a chondroplasty, I would anticipate they'd rehabilitate for 2 months and hopefully be at MMI or ready to return to all activities by 3 months. A microfracture, they're definitely going to rehabilitate for 3 months. And I'm looking at the estimated return or maximum medical improvement in 6 months. The reason for this is that those individuals are going to be non-weight bearing for 6 weeks to allow that clot and allow those cells to come into that area and produce new fibrocartilage. They'll actually use a CPM or continuous passive motion machine to simulate that area for those new mesenchymal or stem cells to try to become chondrocytes, although they'll usually become fibrochondrocytes, and they're going to produce that fibrocartilage. After that type of surgical intervention, by the time they get to 3 months, they can do more loading activities. But even in our athletes, we see it takes somewhere between 6 to 9 months for these individuals to get back to the activities they want to do. ACI, usually 4 to 6 months of rehab, usually takes 6 to 9 months to have improvement and return to activities. I will tell you that they'll continue to improve for a whole 12 to 24 months after the surgical intervention. That cartilage will continue to mature or maturate over time. Articular autografts, usually 3 to 6 months of rehabilitation. Usually by 4 to 6 months, those individuals are going to be able to return. I think that's probably the best operation you can do if you have a small lesion. I think that you reproduce the cartilage surface and it's more anatomic. You're using normal cartilage to recreate that. You're using the patient's own cartilage to recreate that. Osteoarticular allografts, usually 4 to 6 months, and usually takes 6 to 9 months to reach maximum medical improvement. The reason why is because the osteoarticular allografts, you're putting in cadaver tissue. Your bone has to grow into that tissue and then replace all of that bone. During the time that your bone is doing what's called creeping substitution, that allograft can actually fracture. So you have to avoid significant loading activities for the first 6 months to allow that to happen. Once that happens, then those individuals can progress to doing loading activities. So I'd like to obviously to thank Excel and Optimal Work Comp Solutions for allowing me to talk, and I'll answer any questions you have at this point in time.